Welcome to this lecture. In this lecture, I'm going to be discussing the cognitive behavioral frame of reference and how we use it in occupational therapy. So the cognitive behavioral frame of reference is based on the cognitive behavioral theories that we draw from the field of or the discipline of psychology. Cognitive behavioral theories, they inform the use of cognitive therapy, or popularly known as CBT in psychotherapy. CBT itself, as a therapy, has a strong base of evidence in wide context, and it draws its knowledge mainly from the behavior therapy and cognitive therapy approaches. Touching a little bit on behavioral therapy has got two main aspects. The first one is called classical conditioning. If you know the popular Pavlov's experiments with dogs, which is about learning by association, where a neutral stimuli becomes associated with a natural response. If you remember the Pavlov's experiment when he was ringing a bell and then providing the dogs with food, and then the dogs then learned to associate ringing of the bell and the coming of food, and then whenever he rang the bell, even if he withdrew the food, the dogs will still salivate because they associated ringing of the bell with the coming of food. The other aspect within behavioral therapy is operant conditioning. This is it comes from the work by Skinner in the 1930s, where Skinner postulated that behavior that is rewarded will be repeated, and behavior that is sort of like punished will diminish. So this was around 1930, around 1939 when Skinner proposed these theories. So these theories actually inform the approaches or interventions used when we are using behavioral therapy. And then cognitive therapy. It uses the assumptions that the thoughts shape the feelings and the behaviors of an individual. So negative patterns or negative thought patterns can be identified and replaced with healthier thought patterns, leading to a positive change in terms of one's behavior. So that's about behavioral therapy and cognitive therapy. All these therapies, they are actually not occupational therapy, but they are separate therapies. But the CBT, which is also not occupational therapy, it draws a lot from behavioral therapy approaches as well as cognitive therapy approaches. So it's like a combination of cognitive therapy approaches and behavioral therapy approaches, and that's why it's called cognitive behavioral therapy. That is CBT. Looking at the key assumptions for the cognitive behavioral frame of reference, take note the language that I'm using. I'm saying cognitive behavioral frame of reference. I'm not saying cognitive behavioral therapy. So the first assumption is that what we think influences how we feel, how we behave, and how we react to our environment. The second one is that identifying and changing negative cognitions, as they are called in cognitive behavioral theory. Changing negative cognitions can change mood and can also change someone's behavior. A consistent rationale for treatment enables occupational engagement by identifying and altering those negative beliefs. So the cognitive behavioral frame of reference in occupational therapy, that's a significant assumption because then it links to occupational engagement. Just to clarify, cognitive behavioral therapy is not occupational therapy. There is some work that was done by Edward Duncan where he was doing a scoping in terms of identifying the aspects of CBT and the aspects of OT and to see whether there was an overlap. And that diagram there from Duncan 2003, it shows that there's some overlap in terms of what happens in CBT, cognitive behavioral therapy, and what happens in occupational therapy. But these two are not the same thing, they are different. Even though we have some occupational therapists who are trained as CBT therapists, so they can actually provide CBT, even though they are also occupational therapists. But for the purpose of our learning this frame of reference, we are making that clear distinction that CBT is not occupational therapy. So the use of cognitive behavioral approaches or theories within the core skill OT practice, where our domain of function is occupation, it is always better for us to refer that as the cognitive behavioral frame of reference that we'll be using, rather than to say we are using CBT in occupational therapy. There has been some criticism in terms of the use of CBT in occupational therapy. Some critics say the use of CBT without a direct focus on occupation has been criticized for role blurring and diluting the therapeutic expertise. Because if someone is an occupational therapist, but they're also trained to deliver CBT, and when they deliver CBT, they might be sort of like a role blurring in terms of what exactly is OT here and what exactly is CBT here. So that's one. Then another concern as well that has been raised by critics is that the use of CBT by occupational therapists sometimes can be seen as a response to dissatisfaction about the perceived effectiveness of OT and a desire for enhanced professional respect. So this is what other authors actually identified. Right, so moving on. Who do we use the cognitive behavioral frame of reference with in occupational therapy? So usually, this frame of reference will be used when we are working with service users who've got quite a number of conditions affecting their cognition as well as their behavior. So mental health conditions, we normally use CBT frame of reference as well, amongst other frames of reference that are used with service users with mental health conditions. So conditions like depression, anxiety, OCD, post-traumatic stress disorder, substance abuse, personality disorder. It's also CBT, cognitive behavioral frame of reference in occupational therapy is also used with service users who've got chronic pain or chronic fatigue. Moving on a little bit to go into the theories on cognition, there is the Arons-Beck's cognitive triad. So what this triad basically demonstrates is that the way we think about something affects the way we feel about it, which in turn modifies the way in which we behave in response to it. So, for example, starting with an individual who views themselves as worthless, what then happens is that they start to develop negative views about the world around them, where they think everybody has them because they are worthless. And then that in turn brings in negative views about the future, where they say they will never be good at anything because everyone has them. So it's sort of like a vicious cycle that then develops. But if we are to track it back, we'll see that this negative vicious cycle is actually stemming from negative views about oneself. So that's Arons-Beck's cognitive triad. But then, if you like, this is sort of like this image, sort of like an advancement from Beck's triad, because in Beck's triad we have those 3 points, but within this this diagram we actually have a lot more aspects that can actually influence the way we think and influence the way in which we behave. So their thoughts, their physiological responses, their emotions, all these can influence one another. As you can see, the arrows are actually pointing in both directions. So these can influence one another. And also, more importantly, is that the environment where the person's context, as well as the physical environment and their social environment, also plays a big role in terms of modifying the way in which they think, the way in which they behave, and the way in which they respond to the environment. Moving on to the hierarchy of the levels of cognition. So there are 3 levels. So cognitive behavioral theories actually present 3 levels of cognition. The first one being the automatic thoughts. These are often thoughts that are uninvited, and they are immediate thoughts that just pop in our brains. And one of the examples of automatic thoughts is where somebody tells themselves that, oh, I'll sound stupid if I ask a question in class. It's just a thought that has not been invited, but it just pops in the brain. And then the second layer after the automatic thoughts is the beliefs, or sometimes some texts refer them to as conditional beliefs. These are beliefs that we hold about ourselves as individuals, and they lie just beneath and shape the automatic thoughts that end up popping up into our heads. These may be unhelpful. For example, somebody might actually say, if I can't do my job perfectly, everyone will think I'm a failure. In reality, that may not be the case, but then it's a belief that somebody starts holding about themselves. That's the second layer. And then the third layer is the core schemas. So the core schemas, these are core beliefs and assumptions developed from childhood about ourselves. So as we are growing up, we are developing certain beliefs about ourselves, about who we are, about the people around us, about the world in which we are situated. These sometimes may also be unhelpful, particularly if we are looking at people who are having mental health conditions. They are more likely to end up having some unhelpful core beliefs. For example, where somebody just believes that they are worthless from childhood, depending on what they were experiencing, until they are an adult, they still hold that belief that they are worthless. So it becomes actually a core belief. So these are the 3 levels of cognition according to cognitive behavioral theories. Now, it's important for us as occupational therapists, when we're using the cognitive behavioral frame of reference, to have an understanding of these theories and where they're coming from, so that when we are designing our interventions guided by this frame of reference, we can then be able to address the cognitive distortions and faulty ways of thinking or bias in thinking. And these are some of the examples. For example, overgeneralization, where a person makes a general conclusion based on one experience. Maybe they failed in one occupation or in doing one thing, then they then say, I always fail. So they're actually overgeneralizing. There's also what is called personalization. Personalization relating to external events to oneself without any justification. If anything goes wrong, the person will just think it's their fault, even if they are not involved. Anything around them that goes wrong, they'll say it's their fault. When they see people talking, they'll just say, these people are talking about me. And more usually, pathologically, they will be like, they're saying something negative about me. Or they just think that, okay, they think the person is a fool. So this is personalization, where the person is actually attributing external events to themselves as if they are the ones responsible. So this can actually hinder a person's engagement in meaningful occupations. Then there's also catastrophizing. This is about magnifying negative aspects of a situation. For example, one says, if I mess up this presentation, I'll be fired. So they're sort of like blowing it up, really, catastrophizing a situation. There are also other examples like dichotomous reasoning. It's sort of like a black and white thinking in terms of, oh, if I can't get it right, then there's no point of doing it at all. There is also another example of cognitive distortion called arbitrary influence. So with arbitrary influence, for example, a person who is studying a course, they can just say, on the first day, they'll say, this course is actually rubbish. They've just attended maybe one session. They don't know everything about that course, but they just conclude. So that's arbitrary influence. Here are some more examples of information processing errors. So when we are working with our service users in occupational therapy, we might be getting some of these statements from the service users as we're doing our assessments or as we're providing our interventions. So if we're using the cognitive behavioral frame of reference, it's important to be able to pick out or to identify these information processing errors so that we can then be able to help the service user to change their thought patterns and then end up influencing their behaviors and the way in which they feel about themselves or about their occupations. Looking at some of the assessments that we can use in occupational therapy, and I need to clarify here, these assessments are for occupational therapy. So they are not assessments for CBT. These are assessments for occupational therapy when we are using the cognitive behavioral frame of reference. Of course, there might be an overlap in terms of how assessments are conducted in OT and how assessments are conducted in CBT. But it's important to keep that distinction between OT and CBT, and I'm focusing on occupational therapy. So we could use structured interviews where we get to find out from the service user what is meaningful to them, what roles are meaningful to them, what occupations are meaningful to them. We can also use observations, and then we can use activity diaries where they document their occupations throughout the day or throughout the week. And then when we review that week, we can then be able to identify areas maybe that need to be addressed or to be filled up with meaningful occupations. We could use different Likert type of questionnaires to get to know maybe the person's interest, what is it that they value. We can also use the AMT, that's the abbreviated mental test, role checklist, routine task inventory, behavior rating scale. We can use the MOCA. We can also use the MOHO-based assessments. That's the MOHOST, Model of Human Occupation Screening Tool. We can also use the OSA. We can also use the functional independence measure. There are a number of assessments that we can actually use. There are many more, but these are just some of the examples. And it's also about making those decisions whether the assessment needs to be standardized assessment or non-standardized assessment. And then for the interventions, this list is not an exhaustive list of the interventions that we could use, but we can actually be able to use graded activity scheduling, finding out the person's weekly activities, they complete a log, and then we then try and incorporate a range of meaningful occupations or activities, especially in the areas where there are gaps in activity or where there are areas that show that the person is not having any meaningful occupation to be engaging on. We can also use creative media in occupational therapy, so that could include art, that could include picture collage, that could include pottery, and things like that. It could be drama. Yeah, so we could use these as part of our interventions, but it's also important to realize that we are not art therapists, we are not drama therapists, but we can still use the creative media in some of our occupational therapy interventions because those aspects are also linked to human occupation. So automatically it makes them eligible for use in occupational therapy. We can also do psychoeducation, where we actually educate the service user or their family about the mental health condition that the person is having, or might not be a mental health condition. For example, in chronic pain, it's educating the service user about their condition so that then we can then develop strategies to actually manage better, as long as the goal is to engage in meaningful occupations. Relaxation, diversion, and distraction. We can also use these sort of like help the service user to actually redirect their attention towards occupations that are more enjoyable. It might be sports, it might be games, or occupations of interest, really, rather than for them to dwell on the negative thoughts or distorted thought patterns that they might be having. We can also use assertiveness training, guided imagery, where we use pictures to ask the service user what they think happened before and what they think will happen after. They then can take a role within that picture to say, okay, this is what would you do in this situation. That actually helps us to understand the idiosyncratic meanings that the service user attaches to the images in guided imagery. And then we can also use a wide range of stress management, stress coping strategies, problem solving, thought diaries as well. But with this cognitive behavioral frame of reference, it's important to use a goal-focused approach. It's also important that interventions are conducted in an educative and a collaborative manner with the service user. Grading of interventions, also very, very important. For example, somebody with anxiety, maybe they are singing or they are a singer, they are struggling with anxiety, performing in front of a huge crowd. That occupation can actually be graded to say maybe they start with performing just to the therapist, and then maybe they perform to two people or familiar faces, and then we keep on upgrading it until they're able to perform to a bigger audience. So those techniques, we actually use them when we're using the cognitive behavioral frame of reference. Okay, and that's the list of the references that are used for this presentation. And this brings me to the end of this presentation. Thank you so much.